Welcome to Pulse&Pressors, where critical care gets crystal clear. ACS is not four separate entities. It is a disease continuum defined by the degree of plaque disruption, thrombus formation, and the resulting severity of ischemia. Stable angina lies at the low end of the spectrum, STEMI at the catastrophic end. Everything else is a progression of thrombus burden, flow limitation, and ischemic depth. All ACS originates from plaque rupture or erosion, exposing prothrombotic material that triggers platelet activation and clot formation. But what determines the clinical phenotype is the balance between thrombosis and endogenous fibrinolysis. Microembolization and microvascular obstruction amplify injury beyond the epicardial lesion. Stable angina results from fixed coronary stenosis, where flow reserve is limited only during exertion. Symptoms are predictable, troponins are normal, and ischemia is fully reversible. This is a supply-demand mismatch without acute plaque instability. Unstable angina is dynamic ischemia from a partially occlusive thrombus or sudden drop in supply. Symptoms occur at rest, increase in frequency, or become more severe. Troponins remain normal because ischemia is insufficient to produce myocyte necrosis, but the risk of progression to MI is high. NSTEMI occurs when the thrombus is large enough to cause prolonged subendocardial ischemia and cell death. Troponin elevation confirms necrosis. Without full occlusion, there is no transmural infarction and no ST elevation. However, NSTEMI patients often have a higher long-term mortality than STEMI due to multivessel disease. STEMI reflects abrupt, complete coronary occlusion with immediate cessation of flow. Transmural ischemia produces ST elevation, but experts know that not all occlusion MIs produce ST elevation. The myocardium is in a race against time. Reperfusion is the only intervention that saves myocardium. STEMI ECG patterns include ST elevation and reciprocal depression, but expert recognition extends to occlusion, MI equivalence. De Winter pattern, ST elevation in V1 to V3 with left bundle branch block, or Scarbassa/Smith modified criteria. Hyperacute T waves, and posterior MI with isolated ST depression in V1 to V3. These subtle patterns represent full occlusions requiring emergent PCI, even without classic ST elevation. NSTEMI and unstable angina share similar ECG patterns, ST depression, T-wave inversion, or dynamic changes. The differentiator is myocardial injury. Troponin elevation defines NSTEMI. Normal troponins define unstable angina. Dynamic ischemia is the danger sign. Troponin traces the biological reality of myocyte necrosis. Normal troponin in the presence of symptoms suggests unstable angina. A rising and falling pattern confirms NSTEMI. STEMI produces a rapid surge. Interpretation must always be tied to symptoms and ECG, because troponin elevation alone does not define ACS. High-risk clinical features: hemodynamic instability, pulmonary edema, refractory chest pain, syncope, or ventricular arrhythmias override ECG subtleties and push patients toward early invasive management. These findings indicate large myocardial territory at risk. Echocardiography provides immediate prognostic and diagnostic clarity. Regional wall motion abnormalities identify ischemic territory even before ECG changes develop. LV function helps determine the urgency of intervention and whether mechanical complications, papillary muscle rupture, ventricular septal defect, acute MR, may be evolving. Cath lab decisions follow physiologic urgency. STEMI requires immediate reperfusion. NSTEMI demands early invasive evaluation for high-risk patients. Unstable angina requires urgent but not emergent angiography. Stable angina is elective. This tiered urgency matches ischemic burden with the tempo of intervention. Experts recognize subtleties: occlusion, MI, without ST elevation, posterior and high lateral AMI, global ischemia reflected by diffuse ST depression with ST elevation in AVR, and spontaneous reperfusion patterns where ST segments normalize, but wall motion abnormalities remain. These distinctions determine who needs emergent cath despite modest ECG findings. Escalation is driven by the persistence of ischemia or the emergence of instability. Refractory chest pain, worsening hypotension, arrhythmias, and signs of mechanical complications are red flags demanding immediate cath or advanced hemodynamic support. The algorithm is structured. Confirm ischemia, integrate ECG, troponin, and symptoms, define the ACS subtype, align cath urgency with physiologic ischemic burden, and treat the coronary pathology as early as possible. This is Pulse&Pressors, reflecting on the marvels of the human body. Subscribe to stay sharp.